Welcome everybody to our severe maternal hypertension workshop. Our leaders, I'm your QI, maternal QI specialist for TIPQC. We have Dr. Connie Graves, Dr. Danielle Tate, and Dr. Jessica Young. So welcome them. Our agenda today, we're going to talk about our project kickoff, our overview of our project toolkit application, our data collection, blood pressure cuff, the National Preeclampsia Foundation, our A1 resources. Our pilot teams are going to share, so I'm hoping that they are on. If not, we will share with you their information they've provided for us. At the end, we'll have a Q&A, so if you have any questions for any of one on our team or with Preeclampsia Foundation, please type in your questions and Terry will make sure that we get those asked for you. First off, we're going to start off with Terry Scott, who is our data manager for TIPQC. And if you need anything with TIPQC, that's Terry. Are you ready, Terry?
I sure am. Thank you. Can you click on the next slide, please? So really quickly, wanted to go through the data details, what we're projecting or what we're proposing for this project. And I know obviously we have some team members who are here who are part of the pilot teams. We have some folks who are attending today that were able to join us for our infomercial. But for those who haven't really been able to get a lot of details or just haven't been able to attend yet, we're going to walk through it at a very high level today. And just as a refresher for everybody who's attending. You can hit the next slide, please, Bonnie. So in terms of measures, the great thing about this particular project, you've probably heard a lot about AIM, the Alliance for Innovation for Maternal Health, the last few days, which is with ACOG. They have a hypertension bundle project put together, and they have very specific measures that are defined for that bundle and for that project, and we are going to be utilizing them. So if you hit the next slide, there you go. So those do include the outcome measures, the process measures, and the structure measures for this project, which is how we do all of our QI projects, but they're already predefined. And one of the nice things that's going to happen with that is we're going to be able to compare ourselves to the other states and the other hospitals who've actually run this project as well and be able to compare ourselves. Next slide, please. So in terms of outcome measures, if you hit next, again, it's all focused on severe maternal morbidity. But in particular, it's among two different groups of women, and if you hit next, Bonnie, the first one is all mothers during their birth admission. And then there's actually a subset of a population that we're looking at that if you click next is the preeclampsia cases. And so severe maternal morbidity is one of the outcome measures that is tracked across all of the AIM bundles. But in particular with this one, we're also going to be looking in the preeclampsia cases. Next slide. As far as in process measures, if you hit next, there's several of them. One in particular is around maternal safety drills, the number of drills that you're performing in a particular quarter, and what are the topics. Provider education, so this has to do what's the cumulative proportion of your providers that have completed a particular type of education. Next is also nursing education, again, in your nursing staff. Next is, and this is the big one, this is really the one that our pilot teams have really been focusing on and that you're going to be spending the most amount of your time really looking through your records and as far as your PDSA cycles and your improvement efforts on, and that is the treatment of severe hypertension within 1 hour. And in particular, this is two numbers or two counts that we're going to be asking you to collect. The denominator are the birthing patients that have acute onset of severe hypertension that's prolonged for at least 15 minutes. And then the numerator is of those, how many were treated within 60 minutes with a particular response. And that is really, even though it's a process measure, that's really a big one that we're going to be tracking as TIPQC as well as in AIM and across our project. Next, please. And in terms of structure measures, these are a little bit different. This is not necessarily how many. This is patient, family, and staff support. Do you have a support system set up at your institution to be able to support the patients and family and staff? Next, please. There's debriefs. We're wanting to know whether or not you have, again, a system in place to support debriefs. Not necessarily if you're doing them, we want you to be doing them, but we really want to make sure that you have the structure in place to be able to do them. Next, please. Also multidisciplinary case reviews. We want to know if you have, again, that system set up in your institution to be able to support those. Next, please. And then in terms of policies and procedures. Obviously, policies and procedures are ground. A lot of things are very important, and this is the same thing with this project. Next, please. And the last one that actually I find as a data person, really nice to see that the AIM bundles always wants you to have a reach goal of incorporating some of the bundle items into your electronic health record system, because we know that's going to make things more part of the culture in terms of everybody's going to be doing it. It's going to take some of the variability out of the process and make it more straightforward. Next, please. In terms of the actual data collection, when it comes to the outcome measures, next, what the nice thing is that you as an individual team are not going to have to take any action. Next, we actually have been partnering with the Tennessee Hospital Association, and they have actually been looking through your claims data, and they are able to actually provide us that severe maternal morbidity data aligned with the definitions for you. So if you hit next, they actually send us the data on your behalf, and then we actually upload your data into the AIM data system on your behalf. So in terms of the outcome measures, you don't need to do anything regarding that. Next, please. In terms of process measures, this is kind of where your data burden does pick up. Next, please. In terms, again, of that main process measure of the treatment of severe hypertension within 1 hour, next, we are going to be asking you to be monitoring that retrospectively every month. And some of the pilot teams are doing it a little bit differently. Some of the pilot teams are literally reviewing each case to see if they qualify case by case by case by case and telling their numbers that way. Other teams use kind of their EHRs to be able to pull out specific records and specific patients based on criteria, and then they're going through those and making sure their numbers match. Next, please. But in terms of obstetric, the safety drills, next. The provider education, next. The nursing education, and next. These actually are just going to be something that you are going to enter quarterly. So it's not a month. It's just at the end of a quarter, you kind of accumulate your data and put it in there. Next, please. In terms of the structure measures, again, this is next a type of thing that we're going to ask you to capture quarterly. If you go to next slide, please, Bonnie. Thank you. What we actually want you to capture is kind of the completion or the start date of a particular structure measure. You had the process for debriefs in place as of August 1st. You had them in place as of April 1st. And the idea is that you're going to be reviewing those structure measures every quarter, and you're going to be updating them if they change. Next, please. But coming soon, again, this was a very high level introduction today. If you hit next, we are going to obviously be meeting on the upcoming months. In particular, in April is our first official huddle, and we will actually be covering all of the data training and all of the details in that April huddle. And we're actually going to cover everything in detail, and we'll be sending out lots of things. And obviously the pilot teams have had several months to do the data collection and kind of the data entry. And as far as some of our folks that have attended the infomercials, so don't worry if you didn't catch everything. We will be following up with all of you after today's workshop and in time for the huddle. Thanks so much. Does anyone have any, or I guess if you have any questions or comments in the interest of time, you can chat it in regarding the data, and then we'll save those to the end. Thanks so much, Bonnie.
Thanks, Terry. We appreciate you. Okay, so first up, we would like for our teams, our pilot teams, who have been turning in their, huddle reports, their leadership reports. First up, do we have anybody on UT? Is Trip or Megan on, or even Nikki, to give us their overall report and let other teams know what they've been working on? Okay.
Can you hear me?
Oh, yes, I can now.
Okay. Sorry.
Hi, Megan.
This is hi. I was muted on my computer and my phone. So, okay. So we started collecting data prior to the TIPQC project, and kind of got a baseline of where some of our barriers were in treating severe blood pressures within an hour. And so we have focused on looking at the appropriate treatment within an hour, appropriate retreatment if severe range blood pressures still occur, and then also looking at if blood pressures are being checked appropriately and rechecked based on the medication that's given. And so throughout this project, we have been able to increase our rate of success quite significantly. And we also have rolled out a nursing-driven pathway at the end of January that has really helped our response time. So instead of nurses having to wonder when a doctor can get back to them or what the doctor might want to treat a patient with, they are actually able to go ahead and treat with a standard dose of oral nifedipine and recheck. And at that time, they're also alerting the provider that the severe range blood pressure protocol has been enacted and they have 30 minutes to get to the bedside to assess the patient. So we're really excited about that. We're also really excited about the preeclampsia education that we're now giving patients through this project. And overall, it's been really great so far.
Have you found any hiccups that that have happened that you could elaborate on that you were able to overcome?
I think when we first rolled out our protocol, we had a couple hiccups. We noticed that we may need a protocol that's different for triage patients versus inpatient patients, but I think we're working those out. Another maybe hiccup that we had when we were rolling out blood pressure cuff kits is just communicating that to our providers. You know, email can only do so much, so we had to kind of meet face to face to go over who we're looking for to give these blood pressure cuff kits to and why they're important.
Thank you. Thanks, Megan. Okay, next up, we have Regional One Health. I saw Dr. Tate on, who is our leader.
Thank you. So far, our team has gotten off to a great start. You know, right when this project rolled out, it was perfect timing because we were doing an internal review of how well we were treating severe hypertension in our OB/ED. And so with that data, it helped us build a start from that. So now we have a multidisciplinary team involved and we have set out our goals. We've gotten approval through the university to actually make this into a full research project, more than a deeper dive, more than quality, the quality look that we're doing here for TIPQC and AIM. We also have identified IT help to allow us to put in chart alerts and also search what we're doing on a daily basis, which was one of the biggest things that we were concerned about with so many providers going through our OB/ED, being able to keep up with the measures and identifying the patients in a timely manner. We have started re-education for both our nursing staff as well as our physicians and residents included. And so now we're just really moving forward with collecting data so that we can make sure we're reporting.
Thank you. Same question. Any hiccups that you could report that maybe would help another team to keep from having that same issue, maybe?
So I think the biggest thing was realizing our resources as far as collecting the data. I think from our standpoint, we thought we would have to go patient by patient, but when we realized the EMR was our friend and sitting down with IT and learning how to use that effectively, as well as our key team players that actually do data collection for the hospital, that saved us so much time. So I would encourage everyone to try to dig deeper into your EMR. Is going to be your friend. Because you can search for data points, you can set a blood pressure data point and you can search for that and it'll pull all patients in a week's days, week, or month's time that you need.
Thank you, Dr. Tate. Next, we have Baptist Memorial. Is Camille on? Are you muted? I know that they've worked really hard. They started out with their SHIP program.
It looks like Camille is on, but I don't see her as being connected to the audio. Oh, there she is. She's a caller.
There she is. Hi, Camille.
Okay, here I am. All right.
Perfect.
Yes, we started this in January of 19. We educated all of our nurses in October and November of 18. So we have been doing this for a long way. You can see our graph how well we are compliant with the bundle, and that means treating women that are recognized with hypertension in 1 hour. You can see that we started off okay. I didn't include January, February, March, just because we were not very good at all. I started with April, where we kind of we had gotten to a point where we could start keeping data. You can see that we really dipped down in 19, but you can see right where in November and December of 19, we had our educator go back with and talk to our nurses one-on-one, and you can see the great, the great increase in that. Then COVID hit, as you can see, in 20, and we've kind of struggled all during COVID. We're back at it, and the best thing that we're working out now is we're looking at the failures and what failed. Was it nursing that failed to notify physicians, or was it physicians ordering? We're trying to do the same thing as UT Medical, where we're treating and putting the orders in at the same time that we're calling the physician, giving the nurses a little bit of autonomy to go ahead and get started, at least starting an IV, drawing some lab work. We have, which I think is a little bit different, we have about 130 providers here at Baptist for women, and they're mostly private providers. We don't have any providers. We have one physician, maybe two, that are part of our BMH group. So we have a lot of different practices, a lot of different doctors, a lot of different ways to practice. So as you can see, we have kind of struggled the last couple of years. We are now working on our February data, and I have to say that we are doing very good. So far, we've only had 4 failures. I can attribute a couple to physicians ordering an off order, not on protocol, or a couple nurses that maybe didn't they did recognize it, but for some reason didn't document why they did not give the medication. So every day we keep up with it every day and try to find out. Basically, I think where we're looking now is where our failures are. So that's about it. We realized that you cannot turn a big ship on a dime. So we are, every little win we're taking every little win. We're taking it, and we're grateful for every little win.
So what you're saying is, if we can get all providers to practice similarly when it comes to hypertension, it would make your life so much easier.
Absolutely. And, I said this in several meetings. What I would like to see is what happens, the ED, when someone comes in with chest pain, what do? They automatically get an EKG. They automatically give them some some aspirin. They automatically give them some morphine. They draw some lab. And, that way by the time the physician steps in, he's got all the information, or she's got all the information she needs to see if that's, an MI. Why can't we do the same thing? Why can't we recognize it? We're doing great at recognizing it. Why can't we go ahead and get started with that? The 130 different providers has been a challenge.
Yes, they have, the EDs have a code STEMI. So if someone comes in with that issue, so maybe we need a code hypertension, maternal hypertension.
Love that. So anyway, that's how I would love to see it happen. And maybe by the time I retire, maybe we can do this, but that's okay. At least we're making some inroads, and I feel like we're doing a lot better in responding, reacting, and meeting the needs of our women who, in the Memphis area, I know Dr. Tate can attest to this. We have some pretty sick women here in the Memphis, Shelby County area. Sometimes we'll have at least 30 to 70 women per month that have a diagnosis of some kind of hypertension. And Dr. Tate, I know you can probably attest to that. We continue to see very sick women here in this county.
Very true, very true.
Thank you. Thank you, Camille. We appreciate you. Great job. Thank you. All right, now we're going to move on to Eleni Tsigas, and she is the over the National Preeclampsia Foundation, and she has a lot to talk about, but it's also personal for her too. Eleni,
Thank you so much, Bonnie.
I'm going to stop sharing and allow you to share. Okay, go ahead.
All right, give me 1 second to pull it up.
And I have your slides just in case.
Okay. All righty. All right, let me know. Can you see my slides?
Yes, if you'll just, do the slideshow. And
Yep. Got them?
Perfect.
Awesome. Well, thank you so much. It's interesting because we work with states all across the country as they're deploying the hypertension bundle. And most of the time, I really focus on some of the other services and materials and things that we bring to the table, notably patient education materials. You saw one of them in KK Dixon's talk, and we have a lot of other ones, videos and clinic posters and materials that can be integrated into your EMRs. And patient education is obviously a big focus for us. And the Joint Commission, of course, now has actually incorporated several standards, including patient education, into their accreditation process. So if you're a Joint Commission accredited hospital, you have to be doing patient education around hypertension. So that's one thing that we often help with. And another thing is training our patient advocates who are interested in getting involved in QI work so that they can actually participate on some of your committees and task forces to bring that patient perspective to all the work that you're doing. So I'm mentioning those. That's actually not what I'm going to be talking about today. What I'm going to be talking about today is really built on the fact that the Preeclampsia Foundation is a patient advocacy organization, and we do represent all those affected by hypertensive disorders of pregnancy. And as such, our stories, our lived experiences, plus data that we continue to collect on thousands of women really informs our advocacy around healthcare practices, research, patient education, support, patient support. And one of our key theories of change is that effective patient education around signs and symptoms can really enable women to become better partners with their providers. It will help them report concerns that they're having, health concerns, in a more timely manner, and also effectively advocate for themselves to be heard. And one would argue they shouldn't have to advocate for themselves to be heard, but we all know that there are more better and worse ways to really communicate your concerns in a way that you do get heard. And one of those signs, when we talk about signs and symptoms of preeclampsia, one of those signs, of course, is high blood pressure. And it's why ACOG and the US Preventive Services Task Force recommends blood pressure monitoring throughout pregnancy. And of course, in newer guidance now, they're recommending it in the postpartum period, basically about a week postpartum, for all women who have experienced any form of hypertension in pregnancy. However, as we've heard throughout this presentation, COVID and the COVID pandemic has really created an environment where a lot of prenatal and postpartum healthcare visits were being conducted via telehealth, essentially putting the onus of blood pressure checks on the women themselves, often without the proper equipment or training or know-how for how to take blood pressure and how to report accurate readings. And as an aside, both white coat hypertension and masked hypertension can really present challenges to accurate measurements in the clinical setting, and both have been found to lead to cardiovascular and obstetric complications, in some cases equal to those of sustained hypertension. So nonetheless, we responded to this nearly immediate telehealth challenge by mobilizing the Cuff Kit program. So this kit includes a validated blood pressure cuff with batteries, important, and specially created patient education materials that are available in print and online. We have video, we have pictures, we have written explanations, both in Spanish and English, by the way, on how to take your blood pressure at home, measurement logs, and a postpartum bracelet that you can see in this picture that can help women and their providers remember that they're still at risk even after delivery. So in the past 8 months, we mobilized this pretty darn quickly, but in the past 8 months, we've distributed 8,919 cuff kits to 95 sites across 16 states for distribution to their highest risk patients. We are very early in the data collection process, having just received data back from 42 sites on 846 patients, which is obviously a very small subset of the cohort that has received the kits. Of the nationwide numbers, we now have data on 50 of those cuff kits that have been distributed in Tennessee. So I want to report on some of the earliest findings that's coming back from this program. Providers are prioritizing populations at the greatest risk, which is one of the requirements of participating in the program. Of note, 35% have gone to Black women, 12% to Native American women, both who we know are at higher risk for developing preeclampsia than their white non-Hispanic counterparts. They're also distributing them during the prenatal period and the postpartum periods. The N on the race graph on the screen here is a little bit higher since, of course, more than one race can be self-reported. Here's just one quote that we received from a participating healthcare provider. The Cuff Project has been extremely beneficial in preventing patients from needing to physically return to clinic for 72-hour postpartum blood pressure check. We have implemented a program where patients are seen via telehealth visit for a blood pressure check. So here in Tennessee, if you look at your screen, I've just sort of overlaid in yellow how these demographics look for the representation that we have here in Tennessee. So the patients who have received their kits and on whom we have the data, those numbers are in yellow. We know that 54% have been Black, 32% white, and 18% Hispanic. The gestational age that the women receive the cuffs is also a little different than our national numbers, with over half receiving them in the postpartum period, 21% during the second trimester and 16% during the third trimester. Obviously, with only 50, the amount of data reported from Tennessee is not enough for a sub-analysis yet. So the rest of my report is really going to reflect our nationwide numbers. Based on data reported by the participating providers, we are seeing that 33% of the sites report that more than half of their patients are presenting blood pressure logs. 21% of the sites report that about half of their patients are presenting blood pressure logs, and 21% are reporting that less than half their patients are presenting blood pressure logs. Providers are also reporting that the cuff kit is influencing how they manage their patients. Out of 42 provider sites, 20, so almost half, have indicated that it significantly influenced their patient care. 18 sites said that it somewhat influenced their patient care, and a very small number said it did not influence their patient care. We're also collecting some information directly from the end users, the women themselves. Although this N is quite small, and this is data from 44 patients, we are able to glean a few insights. Most women are taking their blood pressure at home, 63% on a daily basis, 9% more than once a week, 5% once a week, and 16% reported as occasionally. Only 7% said never. 90% are keeping logs and presenting them during their encounters with their providers, either via telehealth or in person. Patients overwhelmingly found that taking blood pressure at home, they consider as very valuable or valuable. And they all found the instructions and education that was provided helpful, with 69% calling it very helpful. Overall, we are finding that patients have verbalized very positive experiences and views of the Cuff Kit projects, and the providers are also saying that it's helping them to better educate their patients about hypertension during and after pregnancy. There's another quote that's on your screen there. We have had at least 2 patients return for follow-up emergent care because of high blood pressure detected with the Cuff Kit that may have gone undiagnosed without them. That's what one provider just recently shared with us. So what we really believe from what we're starting to hear from all the sites that are using this, and from our medical advisory board and other clinicians who are practicing in the midst of this pandemic, is that even post-COVID, the prenatal and postpartum model of care is going to change. It's going to continue to change. Certainly, reasons include that it needs to address health disparities found in particularly vulnerable populations. It will probably change to more effectively use healthcare resources. We've heard this quote, the right resources for the right women at the right time, right? So not overusing resources for women who don't need it, and not underusing resources for women who really do need it. Also aligning with patient preferences. A lot of people have actually greatly appreciated certain aspects of telehealth, like not having to drive to an appointment for a 5-minute checkup. While others are concerned that if there is trouble brewing, like preeclampsia, that we may not be able to catch it as quickly as we need to. We also, of course, want to prepare to accommodate new tests and technologies that are becoming available that may turn the current pyramid schedule of prenatal care upside down, and doing more screening in the first trimester. We're also throwing perhaps a more idealistic reason into the mix, and that is that owning your own blood pressure cuff really sets a woman on a path toward lifelong awareness and monitoring of one of the most vital health signs that we will always have, not just during pregnancy, of course, blood pressure. This is always going to be an important indicator of wellness, and a factor of even greater importance to preeclampsia survivors, who we know are significantly, they are at significantly increased risk of developing cardiovascular disease later in life. From a research perspective, there is newer evidence to support SMBP, self-monitored blood pressure programs. Studies have shown that Black and Native American women are disproportionately affected by preeclampsia and hypertension and have higher comorbidities. But they also remain hypertensive for longer periods postpartum, and they have a higher incidence of delayed onset postpartum preeclampsia. SMBP with telehealth protocols like Heart Safe Motherhood or Stamp Hypertension, these are a couple that are being used around the country, have been shown to improve several outcomes, including really eliminating the racial disparities around postpartum monitoring, drastically improving show rates for those who actually do need to be seen, and reducing resource use for women who really don't need to be seen. Some studies have found that blood pressure readings taken at home by high-risk women are actually accurate. I know that accuracy is, of course, one of the things that skeptics will often quote, but studies have shown that they can be accurate and useful. SMBP in pregnancy is feasible and has the potential to be useful in the early detection of hypertensive disorders of pregnancy, but maintaining that self-monitoring throughout pregnancy does require ongoing patient support and enhanced training. There are also several mobile apps that have really come into much greater use, particularly during the pandemic. There are commercial products, homegrown products, a number of different mobile apps and protocols emerging to facilitate home blood pressure monitoring. They don't all necessarily count as self-monitoring. A lot of them are automatically reading and delivering results directly to providers. So what we're essentially advocating for and suggesting is that the Cuff Kit program really could be a basic but critical self-efficacy strategy for high-risk women to help them become active participants in their healthcare. And as a result, really effectively and quickly advocate for themselves and theoretically ultimately lead to improved outcomes. Of course, research is needed to prove that. I mean, this may fall into the category of, do we need a randomized controlled trial to test the efficacy of parachutes? Because this seems so self-evident to us. But in reality, we do need to do the research to measure the impact of SMBP on health outcomes. Additional questions that we're asking, that I'm sure you would be asking, include: how often and when should women take their readings? Do the trends presented in a blood pressure log offer more helpful information than just a single point of contact reading? What should providers do with this information? Ultimately, should this become a standard of care in obstetrics, including, of course, the associated payer coverage for the devices? So I'll leave you with that food for thought about clinical research that's needed, and really invite you to partner with us on a more detailed research study to address what we think are the important questions here. And I would surmise are important to you all as well. So with that, I will leave you. Thank you for your time, and of course, happy to take questions on this at the right time.
Thank you, Eleni. I appreciate you. I'm going to, once you quit sharing, it made it really tiny, so let me get mine up. Thank you so much. Okay. So what we would like for you to do is to, if you have any need for the post-birth warning signs, let Brenda know. It's the most current education for maternal mortality and morbidity. It's best practice on delivering and disseminating consistent messages to our patients and increase their recognition and response. Overview of importance for nurses' role, and post-birth warning sign discharge checklist. This education will be provided, I believe it's 10 seats plus a kit, and it's education for nursing staff, and it's to help save a life. It gives the patient a pamphlet that says, these are the warning signs that you need to be looking for, and to call 911 or a healthcare provider, and it gives them a list of those signs. Also, we're going to be rolling out our simulation training this summer. It'll be train the trainer for local hospital educators. We'll have curriculums for SIMS training, maternal and infant. We'll have on-demand CME videos. We'll be offering a Mama Natalie SIMS for each hospital unit. And you'll see the Mama Natalie, it's got the maternal part and the feed and the baby part. And all of this will be this summer. So if you let Brenda know, we'll get you signed up for it. We would love for you to be a part of this training. So now we want you to ask questions. So you can unmute yourself. You can type in your question. If you are trying to unmute yourself and you can't, just let us know and we'll work on unmuting you. But we would like for you, if you have any questions for Dr. Tate, Dr. Young, Dr. Graves, or Eleni Tsigas, we would like for you to ask them now, and so we can get those answered for you. If about the project, about the Preeclampsia Foundation, about anything that we're offering, we would love to hear from our participants. How would one go about, Eleni, partnering with the Preeclampsia Foundation? I know that we have through TIPQC, but how does someone else do that? Yeah, you're muted. Can someone unmute her?
Okay, sorry about
There you
that.
go. That's okay.
I made the mistake of changing my screen, which means that I lost all my controls.
That's okay.
So, sorry about that. So specifically around the cuff kit program, you can go to our website. In fact, I'll type that into chat, but it's www.preeclampsia.org/the cuff putting that in there right now. And one of the things that we tried to do when we established this, we know that there are some sites that are really optimized for handling research studies and collecting a lot of data, a lot of tertiary care centers, academic centers, et cetera. But we also wanted to make this available to lower resource sites or perhaps community health workers and others that don't necessarily have the robust data collection procedure. So I mention that only because one of the requirements for participating in this is that you're able to prioritize the highest risk women, and we give some guidance about how to do that. And the second is that you do commit to returning some data to us so that we can continue to measure a little bit about who's getting the kits, how they're utilizing it, basically the data that I shared today. And so those are pretty much the only requirements for participating in this. And of course, the funding piece. Now we've worked with Tennessee and TIPQC to identify some funding sources, which is how many of you all are participating in the program. There are little pockets of money that have popped up in a lot of places to address health disparities and to address the COVID pandemic. And I just would encourage you to think creatively about how to use those because we do honestly believe that the cuff kit program is critical for both of those. So that might be a way to identify additional funding for more cuff kits.
Laurie DeSantis asked, have any large academic centers expressed interest in working together to do a multi-center research study on the impact of self-blood pressure monitoring?
We've heard rumblings of it. I would actually love for the audience, somebody in the audience to reach out to probably Brenda Barker, the email that just went up in your chat, because I do know that there is interest in this and we would love to be supportive of that kind of an endeavor, because that's exactly what the point was of my talk, which is to say, this makes sense. I think everyone intuitively understands that this could be a really powerful support tool, but we need the data.
Yeah. And there is some preliminary data out there. There's a good study looking at using blood pressure cuffs in reduction of disparities for postpartum visits. So there is some good, probably not as much data as we need, but there is some preliminary data that is available for anyone who's interested in this to get started with as well. And I'll be happy to send you the articles. If you'll just email me, I'll be happy to give you that bundle of articles. Not very many, but enough to hopefully help with funding.
And I referenced some of those articles in the one slide. I listed a bunch of references at the bottom. So if I'm assuming the slides will be made available to you all, and you can always check some of those out as well.
Yes. Dr. Young, you have something to say? So does anybody have any questions about the Hypertension Project? Because it is going to be a part of the Joint Commission bundles along with hemorrhage, and that the hypertension and the hemorrhage all tie in also with our simulation training that we'll be doing for facilities who sign up. That way we can help you to get your facility ready for Joint Commission.
I have a question for Dr. Tate and Dr. Graves. How have you all, in the development of this project, been thinking about disparities and how this project can help improve those disparities that we see in our state?
Well, I think that one of the things that we have seen is that protocols help decrease disparities. Fortunately, I think that St. Thomas Midtown may have about 6 years of data because I'd love to, but prior to this, where I would love to look to see if we've had some decreases in our severe maternal mortality around African Americans, and I think it is directly related to these protocols and bundles. So I think that when we standardize care, and when we don't put patients in certain boxes, for example, I've heard people say, well, African Americans have higher blood pressure or those types of things, but everybody gets the same care. I think you see this decrease in disparities. And so these bundles not only speak to improve care for everyone, they're also a way for your to drop disparities in your patient population. And Danielle, I don't know if you looked at your data with bundles.
Definitely. So I definitely agree with what Dr. Graves said. Also, too, I think it will help with the standardization, will help us to kind of combat the culture of OB, in that a lot of times we want to go experience-based and not evidence-based. And a lot of times that will delay or even prevent someone from getting adequate care. And we see our rates of adverse outcomes go up. I hear so many times, well, she was on her phone texting, that's why her blood pressure's up. Or, oh, well, you walk in and it's the culture of the hospital to take every blood pressure while the patient's lying flat on her back. So those things are forcing, with bundles like this, forcing us to all practice that evidence-based medicine, and also giving hospitals like community hospitals, I work at one, the staff there kind of that courage to navigate through all of those different providers and their special, unique ways of practicing. You have that bundle to blame and that bundle to fall back on to say, it's not just me picking at your 30 years of experience. It's the evidence, and it's been proven that we need to do these things for the patients. And I think it also, with standardization, it allows us to see past what the patient looks like, right? Or what her situation walking in the door is about, or her social situation, and just address the facts at hand.
Yeah, I think the other thing is it helps us to stop minimizing. We get into that tunnel vision, and I recently reviewed a case, and you could just see the patient's blood pressure is 200 over 110, but she's contracting, and then I started down this whole she was anxious, she's delivering, until the patient stroked. And so, but they started down this whole kind of process of having tunnel vision, and I think those bundles allow us to be able to pull back and say, hey, no, this patient just meets criteria.
Right, let's see if we have any. I don't see any questions. Anybody have any questions who wants to open up your line and ask our questions to anyone on our panel?
I did have a question about the home blood pressure monitoring kits as we go into this, opening this up as an option for a lot of the hospitals, troubleshooting with accurate monitoring, because I know that came up with our team as we have patients of different sizes, and maybe the standard cuff is not appropriate, or even how do you go about, really getting the take-home message of this is not for the family, right? It's not for everyone. You need to monitor your blood pressures, or, don't wait when to call. I don't know if any of the teams who've reported back to you have given anything about that experience.
Yeah, happy to address some of those. Let's start first with the accurate blood pressure monitor size, the cuff size, which of course is one of the most common contributors to inaccurate readings. And when we mobilized the kits, one of the things we looked for was, number one, a validated cuff in the upper arm size, and also recognizing that the more consumer grade cuffs, which we knew were the ones that we had to source, would not work for morbidly obese women. And so we found what really was one of the most accurate wrist cuffs. And so when we distribute these, we do ask providers how many upper arm cuffs they need and how many wrist cuffs they need. And we distribute it that way. Now, the best wrist cuff in the world is not ever going to be as accurate as an upper arm cuff. And we know that it's unfortunately, we're in a state of this is the best we're going to be able to do, but we have felt pretty good about the wrist cuffs that are going out. So hopefully that answers the question about sizing and then the validation, which is something that we worked hard to address. And Dr. Tate, what was your second question? Because you had another one too.
I was just interested to see if any of the teams reported back any troubleshooting with just patients really understanding the importance of logging, of use for them and not family members, of even when to come to the hospital.
Right. So a couple of things. One is we've tried to preempt that as much as possible by putting the materials together in as low. We're really employing the skills and techniques of low health literacy. Not because these may not be going to highly literate people, but even highly literate people can have low health literacy. So we've really used things like the green, yellow, red cue for what your blood pressure number is and what you should do with it. And that's really peppered throughout all the materials. We have a video you can watch about how to take your blood pressure, the printed materials, the online materials, everything reinforces the messages over and over again about how to do this accurately, how to use the log. We also offer a couple of mobile app logs that people can use. Interestingly, the thing about this isn't for your family. I would actually challenge that a little bit, because I think the more you do engage the family and really strengthen the idea that your blood pressure is a lifelong indicator of your health, and all members of the family should be on top of this. I think it can actually make it a little bit more fun and interesting for, it's okay, everybody, time to take blood pressures, and instead of making it just be about, mom is sick, and so that's why she's taking hers. And so, I would challenge that a little bit, that I actually think it would be nice to engage the family. And that's one of the things that we hear, even when it comes to postpartum and doing things that can mitigate your own health risks, like diet and exercise. The more it becomes a family affair, the more women are willing to do those things. It's really hard as a young mom with a baby at home, if she's got to have her own diet and her own exercise plan. That's just not going to happen. We all have, for those of us who have had children and know what the craziness is of life with a young baby, the more things are family affairs, I think the more you're likely to get buy-in.
Yeah. In our office, before we even had the cuff kit, when we asked people to monitor at home, we gave them a handout sheet, and we had translated into Spanish, and we gave the patient exactly how they're supposed to take their blood pressure, when they're supposed to take it, what position they're supposed to take it in, because, either I have people who take it every never take it, or people who take it every 5 minutes, and then they're calling saying their blood pressure is high because they've worked themselves up into a frenzy, so as to speak. And so I think having I think the Preeclampsia Foundation materials are excellent, but I think if they have a home cuff, also reproducing those materials to give to people who have cuffs they purchased other places. And the other thing I think for validation is I will bring the patient in when she leaves, and I give her the cuff. We will go up to the front and I'll have my MA validate her cuff. So if it's 10 off from our cuff consistently, I'll tell the patient, okay, your cuff is 10 off from our cuff. We've done this 3 times. We have 3 readings. So subtract 10 or from your cuff so that this doesn't stress you out. And so that's another way, I think, because all cuffs read a little differently, but I think it's important to validate them in the office with the standard cuff that you would use, hopefully manual blood pressure cuff you have in your office and not the automated one, and compare it to that, as the manual cuff is the gold standard. And I think that's another way you can overcome some of the variants.
And I also think that one of the issues around being concerned with the accuracy of these home blood pressure cuffs is by encouraging the moms to take blood pressure on a regular basis, not on every 5-minute basis, but on a regular daily basis, let's say once in the morning, once in the evening, and keeping a log of it. fundamentally, I think the trends are going to be more helpful to you all as providers than just a single reading that may, you know, hit the threshold of a preeclampsia diagnostic number or something to that effect. It's just, you'll see the trends. So if a blood pressure cuff is off by 3 points, it's going to be off by 3 points, but you're going to see what's happening over time.
I also think it gives the patient a voice. Besides, I just think my blood pressure is high. Where we went to Walmart and we took my blood pressure. This helps them with their own care as well. It helps them become a participant in their own care and helps them with their voice instead of, yeah. That's what I think.
Absolutely, Bonnie. That's it in a nutshell.
Thanks, Dr. Young. Does anybody else have any questions about anything? Please unmute yourself. Lily said empowerment. Exactly. We empower our moms. Definitely.
I just wanted to chime in that I've been providing some links. We actually do have a project page on our TIPQC website that gives you some information regarding our overall project aim, our key driver diagram, the toolkit that we'll be having the teams work through, the data details, as well as the application. So if you're not one of the pilot teams, if you're not one of the new teams that have already been in the process of applying and you are interested in knowing some more details, please feel free to check that out. I also provided a link to the AIM bundle. Again, we're going to be shadowing that, but in case you're interested in looking at the AIM information directly, I've put that. And as Bonnie and Dr. Graves said, this does align with the JCO with those measures very, I believe as far as perfectly as possible. So there is a good overlap between those things.
Thank you, Terry.
I have a question.
Go ahead.
So one of my colleagues did a chart review and looked at severe blood pressures and failures to treat after 2, and a significant percentage at our institution that were happening were related to the 2 severe range blood pressures would happen, that would get recognized, medication order would get placed, and then the bedside nurse would retake the blood pressure prior to administering the medicine, and then the blood pressure would be not in severe range anymore. And so then the medicine would be held. Do you all have any suggestions for that? Like how do you navigate that?
Stop turning them on their left side. No, I'm just teasing. Because that's usually what they do is they turn them on their side and then they get a lower blood pressure. That is actually, I want to, as a point of education, even though it's funny, it actually, if you read old Williams, as a student of history, that was the diagnosis of preeclampsia, the rollover test, not the confirmation that the patient is okay and can go home. So that's probably, but making sure that's one. And it is difficult because I think having the nursing staff involved, Bonnie talked about empowerment. So one of the things that we have done is really make sure that a nurse representative and the nurse, and many of our protocols are nurse driven, so that the nurses have a good understanding of what the protocols really are, because if the truth be told, most of us aren't at the bedside when the patient presents, and so we are relying on our nurses. So I think making sure you have that multidisciplinary team where the nurses are an active voice and an active part of the program is really important in kind of making sure patients get treated.
Yeah, Megan said, the culture of only believing in lower numbers. I do know as a nurse that we are supposed to take a blood pressure prior to administering the medication. And then I do know what our nurses at Regional 1 do is if they do get a lower number, they notify the provider immediately and say, this is what I've got. And then they allow the provider to make that decision.
And Jessica, I just chimed in because it is interesting that AIM metrics were just recently revised. And I find it very interesting. I just chatted it in that they clarified that the hour that you're trying to meet is within from the first severe range blood pressure reading, assuming the confirmation of the persistent through the second. So the hour doesn't start after that. The hour actually starts in the first one confirmed by the second, and then that. So that, I mean, even like I said, AIM revised their metrics to better align with the ACOG definition. Connie is nodding her head. I know she knows. So that may also be just kind of, again, a re-education type of thing of when does that hour start? You know, when is the confirmation? What is the process of it?
Well, and I think my guess is the concern is that if the blood pressure is lower, so non-severe, if they give the medication, will it drop the blood pressure too low? And is that a reasonable concern given this persistent severe range otherwise?
Could we do, instead of if they were ordered IV labetalol, if it comes the second, then the next one is not high enough for their perception of labetalol, could be dropped too soon or too fast, give the PO nifedipine instead. And that way we are treating the blood pressures, but we're not doing an IV, which would be rapid descent of blood pressure. It would be a slower, what do y'all think?
Well, I think that the culture of believing the lowest pressure is probably the most prominent. So in the process, if you have two blood pressures within that 1 hour period, the first pressure high, and let's say the second pressure looks, quote, better, and then the third pressure is high. And then of course, in 15 minutes, they said that the patient was lying under a cuff and they, you know, readjust the cuff and then it's still high. I think
you get in a cycle where
Yes.
you're never treating, right?
Yeah, exactly. But I think we also have to remember that every time a patient has an elevated blood pressure, we increase her risk of significant morbidity and mortality, including stroke, myocardial infarction, abruption. So it is not as if, you know, no one wants to drop patients' pressures, you know, down and not perfuse their placental bed and cause a stat emergency C-section. On the other hand, we also need to follow the guidelines, because we do know that women are 12 times more likely to have a cerebral vascular accident during this period where we're trying to decide if, you know, should we or shouldn't we give treatment. But the truth of the matter is the patient's severely hypertensive.
So it sounds like more education on nursing staff to not see it as a bigger burden, but actually saving someone's life. Because I will say that you will hear staff go, well, I mean, I now have to draw blood for tox labs, and now we have to start MAC, and now but you're already monitoring her and documenting on her every 30 minutes. So it only adds one more thing. Actually, instead of thinking of it as a burden, let's think of it just save somebody's life, right? They get to go home hopefully with their baby, and the baby gets to go home with the mom instead of, you know, without a parent. Education.
And also, just to speak to the intermittent, it's a rare find where they're going to go between severe and totally normal tensive. It's usually severe and elevated, but not required treatment.
Exactly.
A patient who's previously normal tensive and she's elevated in every way, you're really not going to, like Dr. Gray said, you're not going to send her into some severe hypotensive emergency situation by helping. But delaying, we never want our delay to be the reason we have an outcome that is unwanted. And that's what I try to teach, you know, my team as well. Believe it when you see it, right? I know we're optimistic by nature in OB. I think that's because we're delivering little babies and it's happy moments most times, but we have to believe what's in front of us. And if we probably did that a little bit more, we wouldn't need a hypertension project and task force and talks from patient stories, right? Yeah. So again, if you have the evidence in front of you, no one's really going to argue with you about doing the appropriate thing, even though the culture may say do different.
Becca Falk asked, can you speak to the challenges and successes for participating facilities where patients need to be transported back to labor and delivery for IV treatment and or MAG from postpartum?
Well, we are actually starting on to work on our postpartum protocol, and we're going to be using Procardia as our first line. That takes care of no IV. And so by the time and Procardia, I have found to be fairly, and Dr. Tate and Dr. Young and who have experience with it may also, I found it to be very effective in the management of blood pressures. And so that really reduces the number of patients who need to go back to labor and delivery for magnesium or for an IV. And when, and at that point, by the time you get down to if you're past your third nifedipine dose and you still haven't made progress, you probably do need to be going back to labor and delivery for magnesium and labetalol at that time. But it gives you at least an hour or so to see if the patient's going to settle out on labor and delivery before having to move them back to postpartum, because that's a challenge for all of us, especially when we have limited space.
Thank you.
And I find one of our biggest things, because we are a pretty large institution, with the postpartum, either persistence or new onset, is aligning management. It's still preeclampsia. And I think a lot of people get confused because there's no delivery into it at that point. So they get much more relaxed as far as making the diagnosis and doing the appropriate things. But once it's there, it's full speed ahead to doing the appropriate things. It's just usually getting people to recognize the change and that it could be preeclampsia. And I've had more than one provider question blood pressure treatment postpartum, as far as if they're asking as if there are different rules to treatment when someone's not pregnant, and that's not true. Preeclampsia is treated the same way, whether she's pregnant or not, whether she's early pregnancy, late pregnancy, it's all the same criteria, and you should have the same sense of urgency at any point.
Yes, and to Eleni, we part of our toolkit was we added to educate. She wanted to know about educating the EDs. We did add that to our toolkit, and we encourage facilities to educate their emergency departments just in case the postpartum patient shows up at their facility instead of another one. And Robin Swaggerty said, I hope I said that right, we have had very good success with a nurse-driven protocol with oral Procardia, which addresses some of those issues.
Yeah.
Perfect.
And I was going to say our protocol is for the postpartum now is the nurse will initiate that protocol. That and after the first one, they'll try to find the provider. And if the provider refuses or does not want to treat, then they have been empowered to go to their charge nurse and things to make sure that patients get appropriate treatment.
So that empowers your nurses too, your postpartum nurses, to be advocates as well, because they work real hard to advocate, but this helps put that in a little bit more control. Thank you. Well, if there's not any more questions, we'll move on because we want to get back to the main stage by 4:30. Thank you so much to our panel for this conversation. I appreciate it. So what are our next steps? Well, we want you to join with our project, and we want to help you begin with your work. So have you turned in your application? If not, look on the TIPQC.org and you can find the application on there. You can send an email to the TIPQC team, Brenda, and we will get that out to you. So our upcoming huddles, April the 27th and then May the 25th. Our learning session is planned for June, but we're going to announce that time later. And they just put in the chat box where you can find the application because we really want you to join with us. We also want you to listen to KK Dixon's story. It's episode number 8 on our podcast. We have some really phenomenal podcasts that come out every Monday, and her story is on episode 8 with Dr. Young. We want to thank you for your dedication to our moms and babies. You've made 2020 a fabulous year of improvement for our state, and I have had so much fun working with you all. I appreciate everybody from the facilities that work with TIPQC, the Tennessee Department of Health, the Preeclampsia Foundation, everybody who has put forth an effort into everything that we do. I appreciate you, and so does TIPQC.